I am Dr. Mohamed Allam. I am Egyptian dermatologist based in Qatar. Before I joined Hamad Medical Corporation here in Qatar, I was working in Banha University, and currently I am the consultant and the head of dermatology section at Khor Hospital, Hamad Medical Corporation, and I am also assistant professor at Well Cornell Qatar campus and the clinical assistant professor at Qatar University clinical dermatology. And nice to meet with all of you today. My point of care advice I give to my patient is good education, because the most important thing in atopic dermatitis is to understand the nature of the disease, because atopic dermatitis is a very chronic condition. It lasts for years and stays with the patients for a long time. So the patient need to understand this chronicity and the remission and the exacerbations and the flares, so they can know what they are dealing with, and we put the management plan according to this in terms of patient education regarding the frequency of passing, the using of moisturizers, how to use the topical inflammatory agents in mild disease like topical steroids, how to choose them, the topical calcineurin inhibitors, the new emerging medications, topical and systemic for moderate to severe disease. So we have to discuss the nature of the disease, its chronicity, and also the burden and the comorbidity, because the burden of atopic dermatitis is too much in terms of the disease itself, in terms of itching and sleep loss, the impact on the quality of life, and the comorbidities, bacterial, viral infections, atopic comorbidities like food allergies, allergic rhinitis, asthma. So we need to give the patients good information about the disease and how we will manage it. The most important mess, because atopic dermatitis in terms of pathogenesis, it is very heterogeneous, but it is type 2 inflammatory skin conditions, and we have also barrier dysfunctions together with loss of diversity in the microbiome, and also genetic background and influence of the environmental factors. So it is very important for the dermatologist and the healthcare provider to understand this. It is type 2 inflammatory skin disease, and it has barrier defects. And it is not important what is like the chicken and the egg. Is it the barrier dysfunction start first, or the type 2 inflammation start first? Because what we are going to do is to restore the barrier and to treat the inflammations, and also to correct the diversity of the microbiota and the abnormal colonization of the Staph aureus. So one of the messes is the food allergy. I wanted to share with you these things, because most of the families and the parents, and if the patient is adult, he always thinking to look for a direct cause for his condition. But this is not possible in most of the cases. Because we consider food, if the patients have food sensitizations or food allergy, it is considered as a comorbidity. Patients have eczema and he have other comorbid conditions like food allergy, allergic rhinitis, asthma. So the dermatologist, we need to unify this language, because the patient should trust us and doesn't hear different informations from different doctors. So I like to consider the food allergy as a comorbidity rather than a direct cause for atopic dermatitis. Also, if you allow me, because this is an important issue, also the steroid phobia is very important because we need to control the flares. And in atopic dermatitis, as I told you in the first section, it is a chronic condition. It lasts with the patient for a long time. So we need to treat the acute flare with something which is very potent to control the disease. Then look for something called the proactive treatment. Treatment to maintain the result for longer time. So we need to inform the patients about the safe use of the topical steroids, and the doctor should familiarize himself with the categories of potencies of topical steroids, and he should use the least potent topical steroids that can control the condition. Then he should have in his mind that he needs to maintain the result with a non-steroid treatment because we cannot use the topical steroids for longer time. I believe the moisturizing of the skin and the emollient is a very good part of the treatment. It is not the mainstay of treatment. The mainstay of treatment, because we need to categorize the disease, because not all the patients will be treated with topicals, and not all patients will be treated by systemic. So in the beginning, when we see the patient, we categorize them. If he will be treated by topical, this group of patients, which is a milder group who has less percentage of body surface and less burden, and so this one we can control with a topical treatment. For moderate to severe, we should think of long-term safe medications that can treat the patient for longer time, because we cannot treat patients with moderate to severe atopic dermatitis with topical treatment. But in all patients with atopic dermatitis, we have to inform them about the frequency of bathing, the non-soap cleansers, the immediate applications of the moisturizers after bathing, the clothing, the environmental triggers, and how to avoid them in terms of clothing, in terms of temperatures, of allergen exposure. So we need to give the patients all this information. I don't think it is good for the patients to adopt a healthy, balanced diet, but there is no current evidence that oral vitamins or supplement will add much benefit to the course of the disease. This is very, very important areas that we need to discuss with the audience, because as I mentioned, moderate to severe atopic dermatitis, it has a great burden. We should feel the patient perception. The patient's really suffering from itching, from sleep loss, from the symptoms he has, and the clinical signs, and the eczematous lesions in large percentage of his body areas, and even the impact on the functionality and of the skin and the quality of life, and the presence of other atopic comorbidities. So the need for systemic medication is really present. We really need a lot of systemic medication. So now we have the Dupilumab, the IL-413, and we have other biologics, Trelo and Lebrikizumab, IL-13 inhibitors, and we have the Nemolizumab, and we have also the JAK inhibitors. JAK inhibitors, we need to select our patients. This is my advice. It is good to have the JAK inhibitors, the baricitinib and the upadacitinib, which are approved for atopic dermatitis. They have some benefits, and they are good to be there in the armamentarium, but there is يعني boxed warning in the labels, and we need to look for the side effects. But if we look for other systemic medications that we are using, like methotrexate, azathioprine, and cyclosporin, it has also side effects. But we need to select the patients and to follow the guidelines for each medication, and how to select the patient, and how to monitor the expected side effects. Atopic dermatitis is very, very heterogeneous. And even we have changes in terms of T cell differentiation and the polarization, even in the non-lesional skin and the early disease and in chronic disease. And we have a lot of cytokines. First, maybe we have T helper 2 signatures in all the stages, and in chronic stages, maybe you will start to have type 1 and type 17 and the 22 cells and the related cytokines. So the rationale of using the JAK inhibitors is to target multiple cytokines. And it was used, the baricitinib and upadacitinib was used, like you mentioned, in rheumatology. And we have another one also, the APRO, but this one, it will be for atopic dermatitis, was developed for atopic dermatitis. So the rationale behind using it in different diseases, because it targets multiple cytokines at the same time. But we need the molecules, and the efficacy varies from one molecule to another, and the dosage. So in terms of efficacy and safety, we need to look for all these things while we are prescribing the JAK inhibitor. It's a good addition, but it should be in good hands, and we need to select the patients, and we should monitor and choose which is a good candidate for this medication. Phototherapy, sometimes it is difficult for the patients to go to the hospital several times to take the session. It is good option, because each patient is a challenge, and we have a lot of limitations. If you look, we don't look, we look for factors in the patient, factors in the disease, factors in the availability and the accessibility of the medication. So the phototherapy, it has a good treatment options, but the disease also is a chronic disease. So the phototherapy also, it is a good treatment option that we can incorporate. But if it can be combined, all the systemic medication, sometimes it's combined with TCS, the topical steroids, or the topical calcineurin inhibitors, or even some other systemic medications, even in other diseases rather than atopic dermatitis. But I think with the current emerging medication, I think it is easier for the patients if he can afford, or if he has accessibility to the newer medication. I think it could be a good treatment option for them rather than the phototherapy. We need to know the systemic therapy, something like systemic steroid, because the practice in each country differs, because maybe not all the countries they have the whole range of medications. Maybe not all the doctors are familiar with all the medication or have experience to prescribe all the immunosuppressive, or know about their characteristics in terms of efficacy, if it's acute flare, if it's for long term, what is the expected side effects, how to monitor each drugs. So in some areas, maybe we have systemic steroid, but my advice the oral systemic steroid يعني it is outdated, and if it is used, it should be only for very short term control of exacerbation. But we have to think of atopic dermatitis as a chronic disease that need long-term safe medications that the patient can use it for years, not only for a few days or weeks. And we need to know about other systemic immunosuppressants like cyclosporin, very effective medication. But we have limitation in terms of safety if we use it more than 1 year or 2 years. We have the methotrexate, it has its limitation. Azathioprine, it has its limitation. Mycophenolate mofetil. So we need to know about each medications and what it is used for, and how to look for its side effects. I don't think the current evidence and the level of recommendations in all the guidelines. I don't think because if a patients have sensitizations, and if we make test for sensitization and we wanted to refer to the allergy unit and immunology unit for further investigation, it can help a group of patients, but it is not a known used medications by the dermatologist even for severe disease. We can think for the current licensed and approved medications, and if the patients have sensitizations or allergy to some allergens, he can be referred to the allergy and immunology unit for further intervention, because a group of patients may benefit from this kind of treatment. We don't want to think, I mentioned this previously, the patient perception and the burden of the disease. We need to think about the skin diseases, and especially atopic dermatitis, as a systemic, if we can say this, a systemic disease. It has a burden in itself. The itching is a huge burden. If we put ourselves in the place of the patient, he has itching episodes and is not sleeping, it will impact all his aspects of his life and work and school. Also, there is a comorbidities, and these comorbidities we can categorize it into atopic, because the name of the disease, atopic dermatitis. We have atopic comorbidities like food allergies, asthma, allergic rhinitis, like this. And we have non-atopic comorbidities. The most important one, the one you asked about, is the impact on the mental health, and especially in children, and there's a lot of suicidal ideations, attention deficit disorder, a lot of evidence now to the impact of atopic dermatitis on the mental health of the patient. So it really needs to be addressed. Also, the bacterial and the viral infections also is a comorbidities. So we have the atopic comorbidities, we have the bacterial and the viral infection, and we have the impact on quality of, and we have also emerging evidence, the cardiovascular, autoimmune, and obesity, a lot of osteoporosis, a lot of emerging evidence that wanted to put atopic dermatitis as a systemic disease that can be associated with a lot of other comorbidities. Very good questions. For patients with moderate to severe disease, the comorbidities and the burden is even more than the mild disease. And even the treatment, it is very important. Before we have the stepwise treatment. We start with conventional treatment, then we move to the biologic. This trend now is changing. Yani if you can treat the patients from the very beginning with effective medications, you can impact, yani you can really help him, yani theoretically to, yani if there is no a direct, yani we will not treat comorbidities with the treatment of atopic dermatitis, but at least we will reduce the systemic inflammations from the eczematous lesions that affecting, or like psoriatic lesions that affecting large surface areas. So if we control the state of systemic inflammation, probably we can help the patients in other comorbidities we discussed before. And we need to, we have a questionnaires to assess the mental health, and we have questionnaires to assess the dermatology quality of life. So we have a lot of measurement tools. Maybe in the basic clinic we cannot use it, but it is good to look for it. And if the patients can like the heads that target the anxiety and the depression. We have a lot of measurement tools that can, the dermatology life quality of life, that we can assess all what you are talking about in terms of comorbidities and the impact on the quality of life and the mental health. We need to think about the quality of life. Yani I like the concept of the impact of disease on the quality of life and the burden of the diseases, because yani my recommendation or my advice in this regard for all the dermatologists, don't see from your perception only. Yani don't think, yani when you see a patient, don't measure the severity of the disease based on the clinical sign only, and you have to look for how this disease is impacting the patients in terms of his daily activity, yani all aspects of the quality of life and the existence of other comorbidities. We should look for all of these, and we should treat our patient holistically to give him the maximum benefit. Actually, it is, yani, we don't have now the individualized medicine and the precision medicine. Our current knowledge, yani we as a dermatologist or as a scientist or as a physician, when we see a patient, if we can know exactly what is the endotype, the immunological endotype, or if we can predict from the clinical phenotypes or the presentations, what is the cytokines which is elevated in this patient and not in other patients. So we can individualize the patient, because maybe we give all the patients are not responding. Some diseases like in psoriasis, now it is very clear the pathogenic model like IL-23, IL-17. For atopic dermatitis, as I told you, it is very heterogeneous and a lot of cytokines. But also we need to know that IL-4, IL-13 and the existence of Dupilumab, which is approved for long-term controlled, and the medication in the late pipeline which target IL-13 and the newer JAKs, it really gives a benefit. But the variation in the response, if we have something, but there is a lot of things in development like biological markers or some kind of, but up till now, we cannot put it in clinical practice. I cannot recommend a specialty for the because everyone he has his skills and يعني his dreams. So, and each specialty it has its like to say the pros and the cons. So whatever they feel they like to do that, because it is a very long medicine, a very long journey, and you need to study and to read for your whole life. And if you really want to be a good physician or a good dermatologist, you need to read daily. And so it is not an easy things to be a good physician and a good doctors, and to stay with the cutting edge knowledge to give the best service to your patient. So it is very difficult. But I believe, like medicine, it is a very good profession, and it will remain يعني in the highest rank, because we really helping people and doing good to them. It is very important to treat the skin condition, because I don't want to go too much in details in terms of the pathogenesis, but because it needs to present some diagrams. But we have in atopic dermatitis the barrier dysfunction, and this barrier dysfunctions, maybe it is genetically there, or maybe it is induced by the cytokines, by the type 2 inflammation. So it is there in almost all patients with atopic dermatitis. And this barrier dysfunctions, which can allow the entry of allergens and the microbes and the contact of environmental vectors with our immune system. So we have in atopic dermatitis increased bacterial infections and viral infections like impetigonations, and we see a lot of common warts and molluscum contagiosum, eczema herpeticum. And this is considered as a comorbidity. So maybe theoretically, if you have a disturbed barrier, maybe and the loss of diversity of microbiota on the surface of the skin due to this barrier dysfunctions and abnormal immune response, maybe you are more prone to some infections which can invade the skin. But to the current knowledge, there is no data about that patients with atopic dermatitis are more prone to mucormycosis or deep fungal infections. It is not to the current knowledge. There is no evidence for this. And it is good to treat even with anti-inflammatory. If you treat with even topical steroids, you improve the barrier, and you revert the diversity. To the treatment of atopic dermatitis by the current medication, it is good to restore the microbiome diversity and the barrier integrity and function. Wallahi, from my early childhood, I wanted to be a doctor. So I didn't think of something else. So I really love the profession, and especially the dermatology. And when I was a young resident, and I have a good education from my professors. I even loved the specialty, and I'm really working hard to keep my knowledge up to date and to help the patients and give them the best service that they deserve.